2, 1.
Good afternoon. I would like to introduce the final speakers of today's sessions. 3 of our doctors who have worked tirelessly over the years and who've advocated for us relentlessly. And they have recently presented their research findings to the American Society of Mineral and Bone Research. So please bear with me while I read their bios, and then I will turn this session over to them. The first person I'm going to introduce is Dr. Mannstadt. Dr. Mannstadt is chief of the endocrine unit at the Massachusetts General Hospital and associate professor in medicine at Harvard Medical School. His clinical and research interests focus on diseases of the parathyroid glands. He is particularly interested in hypoparathyroidism, and his research spans the basic, transclinical, and clinical realms of the disease. He is the principal investigator of an NIH grant for the development of a long-acting PTH and the lead author of the phase 3 clinical trial of PTH 184 in hypoparathyroidism. Dr. Mannstadt also hosted the NatPara Recall is Over Soon, and he is a medical advisor for the Hypopara Association and a frequent faculty participant at their annual patient meetings. Second, I would like to introduce Dr. Delores Shoback. She is a professor of medicine and the associate program director of the fellowship program in diabetes, endocrinology, and metabolism at the University of California, San Francisco School of Medicine. She graduated from the University of Pennsylvania with a degree in biology and Johns Hopkins University School of Medicine. After medical residency at Johns Hopkins School and fellowship in endocrinology and hypertension at Brigham and Women's Hospital, Harvard Medical School, she joined the faculty in 1985 in the Endocrine Research Unit at San Francisco Veterans Affairs Medical Center. Thank you for taking care of veterans. And the University of California, San Francisco. She is active in basic and clinical research involving calcium sensory receptors, parathyroid disorders, and calcium sensory receptors. She has authored more than 150 research papers, reviews, and clinical and chapters, and co-edited the last 3 editions of the Greenspan textbook of endocrinology and metabolism. Little brain fog there for you. Finally, I'd like to introduce and reintroduce Dr. Lynn Kohlmeier. Dr. Kohlmeier is the director of endocrinology and Spokane osteoporosis, as well as an independent practitioner. After completing her undergraduate degree at Yale, she attended Stanford University for medicine and an endocrinology fellowship. Her internal medicine residency was at the New England Deaconess Hospital and culminated with her postdoctorate degree in calcium metabolism and osteoporosis at the Brigham and Women's Hospital. She is currently in private practice and research studies of bone density, bone quality tests, fracture assessment, and osteoporosis, and these have resulted in many publications. And without further ado, I turn this platform over to them. Thank you for your patience.
Hello, everybody. This is Michael Mannstadt. Thank you very much for the kind introduction, and it's really a pleasure to be here at the meeting. I miss seeing you, and I miss talking to you in the corner in the hallways, but it's fantastic that this conference is happening with so many participants. So next slide, please. What we are going to do is we chose posters or abstracts from the annual meeting of the American Society of Bone and Mineral Research that happened a few weeks ago. And whether or not we are co-authors on any of these posters, we chose them to just tell you a little bit of how research is shared between scientists. And this just gives you a glimpse and is a piece of the puzzle of research. These are often not really finished products, but preliminary results. And so I will tell you about 3 observational studies that explore relevant health questions for patients with hypoparathyroidism, and 1 clinical trial that is NatPara twice a day versus once a day. Next slide. So this is not for you to read at all. It just gives you an impression of how posters look like, and most of you might have seen them, but you have background, methods, results, and discussions. Next slide. So the background for the 3 posters observational studies are that we do need more outcome studies in hypoparathyroidism. And they are often not easy to gain with rare diseases. And so some investigators use large electronic databases like insurance claims or Medicare databases to answer some basic questions about the natural history of the disease. Here, the authors, among others, Lars Reinmark, who you know very well, they used the so-called Explorers electronic medical record database from the United States with data between 2007 and 2019, and they identified patients with hypoparathyroidism. They identified about 2,000 patients who were adults, didn't have thyroid disease within 5 years and were not on PTH. And then they asked how many of those had actually calcium measurements that were at least 5 years apart. And so they ended up with 143 patients that had enough calcium values. And when they looked at the phosphate values, only 31 had enough to investigate. Next slide. And so here you see in this busy looking slide, the calcium values over the 5 years of these 143 patients. And on the left side in red, you see the target range of calcium between 8 and 9. And you don't need to be a scientist to see that there is a lot going on and a lot of values are outside of the range. And it's actually pretty impressive. And so only 41% of the values per patient were within the target range, 28% were above and 25% below. So that's already a very interesting observation. Next slide. How about phosphate? Remember, this group was very small. Only 59% were within normal range or the target range, which is again with the red arrows. And on the right side, the calcium phosphate product, most were within the range, but you can discuss whether this range is actually too wide and relevant. Next slide. So next slide, Amanda. Yeah, thank you. So the conclusions are there is suboptimal control of calcium, clearly. There's a wide fluctuations during the 5-year observation period. And interesting enough, the phosphate measurements were very low numbers, right? So we need to probably measure more phosphate. So the question now is, are these fluctuations, are they related to risk of developing chronic kidney disease or cardiovascular disease? Next slide. That's the next poster. The same group of people used the same database, and here they identified patients who had enough calcium measurements and divided them into 2 groups. 150 patients without kidney disease, the control cohort, and 150 patients with chronic kidney disease, the case cohort. They had a mean follow-up of 2.8 years, and the investigator asked, well, is there any relationship to the fluctuation of calcium with the development of CKD, chronic kidney disease? And the results are here. They are presented for researchers, so they're a little less easy to digest, but I'll walk you through. So on the lowest line here, the less than 33 means patients who had less than 33% of their calcium values outside of the range. So most were within the target range. They were set as the control, as the reference group. And then the one line above, 33 to 67% of values outside of the target range, you see an increased OR odds ratio. It's kind of a risk of 1.36, which means 36% increase in risk of kidney disease. And then even higher or starker is the association here, and those who had the majority, namely more than 67% of calcium values outside of the range, meaning high or low, and there is a 3.5-fold increase in risk. So that's pretty significant. Next slide. So these are the conclusions. There seemed to be an association between CKD and being outside of calcium range. Next slide. So how about the cardiovascular events? There's a relationship to hypocalcemia, CHF, congestive heart failure, and arrhythmias. And here, similarly like before, they identified patients with and without cardiovascular events and enough calcium measurements, 264 in each group, and asked, is there a relationship to the calcium values? And yes, indeed, a similar pattern emerges. You now know how to read this. Patients with calcium values 33 or 6 to 67% outside of the reference range had a 39% increase in cardiovascular events and almost double the risk compared to the reference group if most of the calcium values were outside of the range. Next slide. So conclusion similar to the one before, that there seems to be an association. Next slide. So what can we learn from this, really? And the authors are the first ones to acknowledge that these large databases are tricky because, for instance, they only capture data within a specific network. So if a patient goes to a different network or a different physician, these data are not captured. And then if you compare two groups, for instance, one with CKD, kidney disease, and one without, they might differ in many other aspects that are not controlled. For instance, the diabetes or hypertension. So if in the CKD group there are more diabetes and hypertension patients, well, it's not due to hypopara, really, then the other confounders play a role. But it gives you more motivation for research. And here you see this little pyramid of the quality of research studies. You can have opinions, okay, or you can have case reports, fine, or on the top you can have the best evidence, that's randomized controlled studies, and some of you have participated in those and know how complicated and complex they are, and typically you cannot do it with large cohorts, and therefore cohort studies are actually a nice and valuable tool for researchers, and are really valuable and motivate for further research. Next slide. So now we move to the last poster that I'll discuss, and that is NetPara once a day QD versus twice a day BID. Benefits are clear. BID might offer more consistent maintenance of urinary and serum calcium. Drawbacks are multiple injections. And this handmade graph that's not based on data is just inspired by Forteo PDH1 to 34, which is short acting. You see here in blue, the calcium when you give one injection goes up and then goes down. But if you give 2 injections here in red, the curve looks better, or even 3 injections. The question is, how does it look with NetPara? Next slide. This is this was a phase 1 trial, so really the beginning, creating the basis for future trials, and it only observed the once or twice daily injection for 1 day. So it's not like weeks or months, right? Patients on who got the NetPara injections were not on active vitamin D that day, and they were with or without their usual calcium. And this is, I don't want to go into details, but just tells you that even a simple sounding study, which was led by Steve Ng from Ohio State University, and many centers participated, ours also, really tells you how complicated they can be. So there was a screening visit, then 4 days here in the first screen block, inpatient stay, day -2, -1 on normal calcium trial, and then on day 1 they got 1 or twice injections of PTH, of NetPara, and then they went home, and then they got another hospital stay with the reverse. So if they had twice injections, they got 1, and vice versa. Next slide. Yeah, thank you. So these were the dosing groups: 25 micrograms twice a day, 50 micrograms twice a day, or 100 once a day. And within each group, there were 2 groups. One is without oral calcium, and one with their normal dose of oral calcium. Next slide. So this is part of the results. This is the serum calcium, and very busy slide with lots of data. I don't want you to penetrate this deeply. I just give you a glimpse. So first, remember that the calcium range here is such that small differences look like big differences, but none were significantly different. On the left side of the graph, you see day -1. Remember, that's where patients took their normal calcium trial. And on the right side is day +1. That's when people got once or twice a day net para. And the overall picture really is that there's not much difference in the calcium either between the groups or between calcium calcitriol and net para. Next slide.
Just so you know, you have 3 minutes.
Oh, excellent. Next slide. So this is, again, very busy but key. That's the urinary calcium over 24 hours. Next. So here, as an example, you see in red the group that got 25 micrograms twice a day. Day -1 is calcium calcitriol, and here day 1 is on net para, and you see a nice decrease in urinary calcium even on one day. And this pink graph here on the right, you see the same, but when calcium is given, and you get the impression that the reduction in urinary calcium might be a little dampened. Next. Same is true for the 50 twice a day. Next. And here in black is the 100 once a day. And while there is probably no difference between day -1 in black and on the left day -1 in red, I get the impression that on twice a day it might actually be a little lower. Next. So the conclusions are twice daily PTH or net para was safe. The serum calcium was not different. Net para led to a decrease in urinary calcium in whatever way you gave net para. And my personal impression is that urinary excretion might be a little lower on the twice daily than the once daily. This was a first trial. Longer studies are needed. All right, next slide. So greetings from a beautiful fall in New England, and I'm happy to answer any questions.
Michael, you do have 2 more minutes, so let's see if there's questions. Loretta or Patty?
Okay, Dr. Mannstadt, does aging generally impact the outcomes?
Does aging?
Aging, yes.
Aging. Oh, yeah. So that's a good question. I mean, these studies were not designed to answer that question, but the short answer is yes. For instance, the rate of chronic kidney disease is higher the older you are. And so it is easily understandable that extra factors that influence the kidney function are more pronounced when you're older.
And then someone asked, what are your thoughts on the use of phosphate binders? It was prescribed to me by an attending during hospitalization, but not by my consulting regular endocrinologist who prescribes that pair. Who is correct?
Complicated question. I can't answer your particular case. Typically, phosphate binders are not necessary in most hypopara patients, but in some they are, if despite best efforts, phosphate is still too high. Patients on any form of PTH, including net para, typically have a much better phosphate, and so you should review these data with your treating endocrinologist.
Okay. And finally, someone from Ireland asked a question, and I'm not sure how you answer this one. Dr. Mannstadt, I'm currently still taking that pair through Ireland. Do you think it is dangerous because of the rubber particles, and what are the risks? Thank you and greetings from Cape Benton, Ireland.
Well, thank you, and many greetings back to Ireland. And you must be, you must get sleepy here. It must be late in Ireland. So I would, the politically correct answer is really go by what your endocrinologists tell you. Meaning, if it is allowed in Europe, then you're fine.
Great, Loretta. I apologize. Yep, that's the end of those questions because
yeah, I'll say thank you.
Thank you.
Beautiful. Okay, Dr. Shoback, I'm going to put you forward now. Dr. Shoback, you're muted. Please just press the microphone button to unmute yourself.
Everybody, it's really a pleasure and an honor to be part of this meeting, and I'm so thrilled to be able to share this even in the middle of a pandemic, to be able to talk to you. I like Michael, really enjoy the personal interactions and encounters we have at the regular meeting, and I hope we can get back to that really soon. So I'm going to talk about 2 topics in my 10 or 15 minutes, and the first is the is an abstract that was presented at the American Society for Bone and Mineral Research meeting last month, and that was on the Paradigm Registry. And I bet you that many of you in the audience have been part of Paradigm. So this was poster 776, and it was sponsored by Takeda. Could I have the next slide, please? Before we start, I will remind you that of my disclosures here. The two studies I'm going to talk about are unpublished. They've not been subjected to rigorous peer review just yet. The Paradigm Registry is sponsored by Takeda. And then the Path Forward study that I'm going to talk about in the second part that you've heard a little bit about already is sponsored by Ascendis. And those are my consultancies. Next slide. So what is Paradigm? So this is a registry. And what the goal of Paradigm is to really bring together information, data, if you will, on the long-term safety and efficacy of the use of parathyroid hormone in adults with hypopara in what we call routine clinical practice. So not the clinical trials and not the database studies, but routine clinical practice. And it's going to have two groups of people, people taking PTH 1 to 84 and people on conventional therapy. And so what you're going to see in the next couple of slides is an analysis of 2 years of longitudinal data from the Paradigm Registry that includes the baseline, the 12-month, and the 24-month data. And this is through August of 2019. And the goal and the plan overall is to enroll people continuously in Paradigm and follow participants in Paradigm for a total of 10 years. So this will be a very rich source of data to understand this condition. The target is 900 patients and approximately 300 receiving recombinant PTH. Next slide. And as I said, this is chronic adult hypoparathyroidism. So to be eligible, you have to have the condition for 6 months or longer. And as I said, conventional therapy or conventional therapy plus PTH or PTH alone. Next slide. So this is table 1 from the poster. If we just start at the top, I think you can see that a total of 167 patients have been enrolled and have data that covers 24 months of observation. And if you can see where I've put these big arrows, this registry, the Paradigm Registry, really does reflect kind of what we call the demographics of hypoparathyroidism. Most of the patients, almost 80%, in both groups, both the recombinant PTH group in the middle column and the conventional therapy group in the far right column, are women, middle-aged to older in the vast majority, and about 78% women. You can see the racial breakdown of people both on PTH in the middle column and on conventional therapy. And you can see, if we go down toward the bottom, the primary causes of hypoparathyroidism, that middle column with the blue arrow, the majority of patients, almost 90%, are post-surgical patients. And if we look at the bottom entry in the table, you can see that the duration of hypopara is 9 to 10 years in patients on both PTH and on conventional therapy. So this registry will give us information on truly chronic hypoparathyroidism, people 9 and 10 years into managing this condition. Next slide. This is table 2 from that poster, and I think you can see the information that we're going to be gathering. You can see in the red little box the serum calcium values. Middle column is the PTH treated people. And let's take a look at the mean values for calcium. And you can see they're right there in the target range. 8.6 at baseline, 8.9 at 12 months, 8.8 at 24 months on average. If we look at conventional therapy, over on the far right, if we look at the mean calcium, it's very, very much comparable. So on average, people in this registry represent people pretty well controlled with this condition. If we go down to serum phosphorus, I think the one thing I'll point out to you that patients, the people taking PTH 1 to 84 in the middle column, on average tend to have lower serum phosphate values, 3.8 at baseline, 3.3, 3.3. Whereas on conventional therapy, the phosphorus is a little bit higher. If we look at the serum creatinine and kidney function, and that's the second half of this table, I think you can appreciate that they're very comparable, conventional therapy versus PTH 1 to 84. And the eGFR is just the estimated kidney function derived from the serum creatinine and the body size of the individual. And all of those are on average within the normal range. Next slide. So I think what we can conclude at this first publication of Paradigm results is that there's stability in serum calcium in patients in this cohort at 12 and 24 months. There's a trend for phosphorus to be lower in patients on 1 to 84 therapy, and for it to be stable in the low 4 milligram per deciliter range. And kidney function seems to be consistent in both groups of patients. And we definitely have several additional years of information about both effectiveness and safety of treatment in patients with chronic hypopara that will be coming over time. Next slide. So as Michael has already introduced to you, this is the pyramid of how we in sort of the scientific community view evidence. And so this Paradigm study is right up there. It's right below randomized trials and controlled studies, a cohort study that will give us, see that orange arrow, very important information about this condition and how people with it fare over 10 years of observation. So I think it's a very important study. I want to thank everybody in the audience who's participating, because I know many of you are, and this will be very, very helpful for future studies and for future generations of patients to have this information. So definitely keep up your participation in Paradigm. Next slide. So the second study that I'm going to talk about a little bit was presented in a talk at the ASBMR meeting, but these are results that have come from the TransCon PTH Path Forward study, and they're very fresh results that are available online. If you went to the session presented by Pharma a little bit earlier in today's talks, you've already been introduced to the TransCon PTH molecule, and it's that little orange helix in the middle diagram where the PTH molecule is. It's surrounded by a carrier and a linker, and this allows PTH, if we go all the way over to the right, to be released into the bloodstream slowly over 24 hours. And the goal here is to mimic the continuous infusion of PTH. Next slide. So the Path Forward study design is shown here, and the double-blind 4-week treatment period with the different doses of TransCon PTH are shown in the left. This follows randomization, and that followed a screening period of about 4 weeks. And this was a placebo-controlled trial for the first 4 weeks, and that was followed by open-label extension, which has gone out to 6 months or 26 weeks of therapy. This is all unpublished, but these slides are available online, and still preliminary because it's not peer-reviewed and it's unpublished. Next slide. So the endpoints of the Path Forward study were the proportion of subjects who had a normal serum calcium and a normal fractional excretion of calcium, or at least a 50% decrease in urinary calcium from baseline, and who were off active vitamin D and taking less than 1,000 of calcium per day. And the primary endpoint in the study is really important, because if you don't meet that primary endpoint, it's going to be very hard to say your study was successful. There were also key secondary endpoints at the 4-week time point, which was the primary composite, which I just read to you, and included in there was the percentage of individuals taking less than 500 milligrams of calcium per day. Next slide. There were several additional endpoints, and I won't really read all of this to you, but I think it's very important to know that patient-reported outcomes, including the HPES study, tool, which Dr. Kohlmeier is going to talk to you about, and other endpoints, kidney stones and so forth, and emergency room visits and so forth were also important endpoints of the path forward study, as well as bone endpoints. But we don't have data on that right now. Next slide. This is just to give you a flavor for some of the information that's come out of the path forward study. These are the doses and the number of patients who are on the different doses of TransCon PTH. And you can see that the majority were taking 18 micrograms per day. Next slide. On your left, you can see the mean serum calcium over the 26 weeks of the study. And this includes all of the patients on TransCon PTH at the different doses. And you can see that on average, these calcium values, serum calcium values, stayed within the normal range. And if we move over to the right, you can see the mean 24-hour urine calcium, and the light green is baseline urine calcium, and the darker green is 6 months. And I think if you look across these three sets of bars, TransCon, placebo TransCon, and total TransCon, I think you can appreciate that patients on TransCon PTH, regardless of the group, lowered their urinary calcium on average below the upper limit of normal for both men in red and women in blue. So I think you can see that this is highly effective at lowering urinary calcium. And the little table on the bottom just shows you that in numbers. Average urine calcium going from 400 to 250 on average, and so forth. So highly effective at maintaining serum calcium and lowering urine calcium. Next slide.
Just so you know, you're about 2 minutes or so left.
Great, thank you.
You're welcome.
So just to summarize the preliminary data that we have at month 6 or 26 weeks, 86% of subjects got a normal serum calcium. They came off active vitamin D and were taking less than 600 milligrams of calcium. So that meets the primary endpoint, which is very good for the success of the study. 70% achieved the composite endpoint, which was all of those, and a lower urinary calcium, as well as a lower amount of calcium supplements, less than 500 milligrams, and a urinary calcium either in the normal range or a 50% reduction from baseline. And I can just tell you qualitatively that quality of life scores, both in summary form and in the subdomains, were normal for the TransCon PTH subjects and are being looked at in the Path Forward extension study. Next slide. I'm going to conclude now and be happy to take some questions. Thanks for your attention, and you can take a look at the slides I've shown you, and there are quite a few more in this online website. And as I've already said, the data have not yet been published or peer-reviewed, and this study was sponsored by Ascendis. Next slide. I'll be happy to take any questions at this time.
Loretta, just so you know, probably just one question before we can move on.
Okay. This may be premature, but is TransCon expected to be a more effective drug to manage hypoparathyroidism and hypocalcemia?
Well, we don't have to answer that with scientific data. You would have to really do a head-to-head study, and that has not been done. And I don't even think it's in the planning stages. But I think that I think the preliminary data, which I shared with you, again, it's unpublished, looks very promising for this medication.
Okay. Thank you, Dr. Shoback.
Thanks.
Okay, we'll move on to Dr. Kohlmeier now.
Lynn, you could share your screen if you'd like. You're all set.
Thank you.
You're good to go, Lynn.
Fantastic. Good to be here with everybody virtually. Look forward to in person again, hopefully next year. I want to thank Drs. Mannstadt and Shoback for doing this review and including me. I'm really honored to present two of the abstracts and thank Dr. Shoback for getting permission from the authors. My disclosures are here, and for the two posters I'm going to present, they are Ascendus posters, and we have permission. Some of the authors are listening now. The first one here, number 1 poster, is psychometric validation of the hypoparathyroidism patient experience scale. Many of you have heard about that. And it was actually published in August, and Dr. Broad was nice enough to share that with us, and we can provide that article. You can see it right here is the title. And really one of the bottom lines of this validation of scales of symptoms was understanding and measuring the impact of treatment crucial for patients and adequately reflecting your experience living with hypoparathyroidism, and that's critical to assessing our treatment benefit as well as improving our provider-patient communication. So when you look at the scale, it has a 17 symptom quality. I'm going to show you that, and 26 impact scale, which includes physical functioning and daily life. And you can see participants were over 18, had hypoparathyroidism for over 6 months, and you can see that the patient-reported outcome, which is the FDA guidance, was used with the non-interventional observational study and the phase 2 path forward trial. Interestingly, these were defined as stable patients with at least 3 months with infrequent highs and lows of calcium, which I've added the arrows here thinking that that might be a limitation, and it would be interesting to have the same evaluation with patients that do have much more fluctuating, like I know you experience. And that was the same for the trial participants. They are at a standard care stable dose before entering, before being evaluated. And here you can see the demographics, the mean age in the mid to late 40s. There were, 30 to 20% men, respectively, in the 2 trials. And then when you look at the participants' medical characteristics, I circled here out of interest the percentage of people that were on active D, implying that up to 20 to 30% were not. Over-counter vitamin D3 supplements, and here's hydrochlorothiazide, just 11% in the observational study and less than 2% in the phase 2 study. So really what this paper presents is validation of looking at all these symptoms and having a way potentially to describe them, whether it's cramping or spasming or twitching, differences in how your muscles feel, and being able to explain that, and paresthesia or tingling with or without numbness, and then going from pain to low energy to fatigue, and separating it out into physical functioning, activity of daily life, more of a mood and psychological well-being, and then how that affects plans and social activities that are made, and to have this all come together for this scale, HPS symptom scale. So the conclusion was that both HPS symptom and impact measures developed by the FDA patient report outcome guidance were found to be conceptually sound with statistics that I don't understand, so I'm not even going to show you that. But speaking to the authors and having them explain it to me is really important to validate a symptom scale like this, and that there's adequate evidence to support reliability and validation of measures, which is key if you're going to use that to see if treatments work, to see how standard of care affects different people. So their exploratory hypothesis was confirmed that patients in the phase 2 trial that were off standard of care, defined as off active D, taking very little calcium supplements, but remained on active PTH, showed a greater improvement in their HPS symptom scores than patients that were still on standard of care, and that was significant. And then lastly, to incorporate these tools in future clinic and research. So the second abstract, number 6, many of you here are listening and put this together. It's just fantastic, and thank you for helping me put the slides together as well. Really showed us that 80,000 patients in the United States have hypoparathyroidism, and 200,000 worldwide, and that patients do experience a decreased quality of life. Here you can see the number of participants in the US. There are over 150 people sent surveys, but almost all of them answered. There were 58 online questions sent to Hypopara Association members, and the responses were received between April 30th and May 8th of this year. You can see most, almost 90% were women, average age 50, and they had lived with over half with hypopara for over 5 years. But when you look at the causes of the hypopara, again, most are post-surgical, which you are aware of. But I think this was important to know that more than half the participants had more than 5 physician visits before their diagnosis. More than a quarter, took over a year for their diagnosis, and 10% over a decade for their diagnosis. Nearly all patients received standard of care, thankfully, but 70% still felt that it was very burdensome. And there were patients that were taking PTH, and you can see other phosphate binders, magnesium, and hydrochlorothiazide. And 61% had more than 5 times change, which sometimes is needed and a good thing in their care with their provider. But I think this quote, and I'm going to show you several, are really exemplary, where this hypopara survey participant said that their calcium level sits right at the low end of normal or right below. And if they're having symptoms, often it's called named as anxiety or possible TIA rather than neurosensitivity due to the hypocalcemia. And I think this was a really important finding of this survey, in that calcium crashes, calcium crisis are really not uncommon. So up to 70% experience them within the last year. 43% experience them monthly or weekly, and thankfully less than 5% daily. But that if you look at the 42% that needed to go to the ER, 56% of those patients believe that when they were at the ER, just like one of the presentations this morning, that they weren't able to get their message across, and the staff didn't know how to handle their calcium crash. And of the 90% of patients that are concerned about, aware of the long-term potential risks of hypoparathyroidism, which is why you're here at this conference, 30% realize that there are heart, kidney, and other concerns to look for, and that there is a 4 to 8-fold increase in the risk of kidney disease in patients with hypoparathyroidism. And I love this artistic look at kind of throwing everything together, but the bigger the words, the more of concern patients in the survey had, and calcium crash and managing symptoms are right up there at the top, where fatigue and brain fog and muscle complications have completely changed who I am, this participant says, and how they can function. And because the symptoms aren't easy to see, he or she feels that people don't understand, and they feel isolated. I think one of the important aspects that we as providers can get from this, and you as patients to help providers, is the importance of finding the provider or the doctor, nurse practitioner, physician assistants that understands, a specialist that can help your primary care doctor or your local endocrinologist. And so I think that's where, when they summarize the challenges, I want to add solutions. And what are the solutions? And I think a lot of you have shared your own pathway to feeling better and finding a solution. I think that summaries here are that despite treatment with standard of care, more than 2/3 of patients still experienced crashes in the last year. Almost a half visited the ER or urgent care to address these symptoms. And the majority of those that visited the ER had to receive IV calcium. And that there's an urgent need for more education around hypoparathyroidism, and how do we support you, and how do you have the best treatment that you can have. So I'm going to stop there, and if I have a few minutes, I'll take questions, but I also have some of the results from the Exercising Wisely survey that Amanda sent, and I think about 35 of you answered it. So let me know what would be best to do first.
I think it would be great if you could go ahead and do the survey. I think that would work out really great. We'd love to see that.
Great. So these are just 2 extra points from the patient survey from the abstract of voices that I wanted to share with you if we had time, especially with COVID and all of our concerns. I was relieved that we don't feel that there's an added impact, but that the fear to go into the urgent care or to get shouldn't be swayed with COVID. I think that's an important point. So I do have the questions later on in the slide deck too, because you can't see exactly what the answers are, but I'll just go through the answers quickly, and then we can talk about it, because what you did in the other section is you added your own comments, and that was really helpful. So this is looking at how many of you exercise or participated in high-level activities since your diagnosis of hypopara. And you can see that it's all over the board, which is true for all of us. But there are a lot of you that really did, you can see the numbers here, and that the higher the number, the higher the bar, did exercise, still do exercise with your diagnosis of hypopara. But before your diagnosis of hypopara, it's much more swayed towards exercising and being active more frequently. And I think that goes without saying, and we knew that was going to be the response, and the question is, what can we do about that? So this was, how do you prepare for exercise or participating now with your diagnosis? And some people said, you know, they didn't, one of the choices wasn't really their choice. I'll tell you what they said, and that we should also be able to choose more than one. I think that's a good point. But you can see that most people said other, and I can read to you what those comments were. But that in the first 3, you can see that the hydration was really important. Taking a calcium before exercise or after, depending on what works best for you, really trial and error. Many of you said that you want to make sure that a day or 2 after you exercise or are more active, that you allow for times to rest, so you don't plan things right in a row, and that you give yourself time to kind of recuperate. And often the time of day that you exercise really makes a difference. And then if you have symptoms, what do you do? And again, being able to choose more than one of these was a comment. Maybe you do all 3, but depending on your kidney safety, you can't just take an extra D. So it was really taking an extra calcium that most people chose, and I'll go back and look at what timing that was. But also, many of you just stop what you're doing and rest if you're getting symptoms during exercise, and I think that's a good safety measure as well. And then I think this was to be expected, but also important, is that now with your diagnosis, if you're really extra stressed or sick, you don't exercise as much as you would have before your diagnosis. And so that's why really it was never or rarely, if you're already under the weather, it's not a good time to push yourself to exercise, where before your diagnosis, it might not have mattered as much. And then lastly, and I think what was really important for me, was how can we make a difference for you in the medical community? And I think, you know, what can you do to help improve your activity level? And I'll read through it, or maybe we'll have a webinar Deb mentioned where we can go through some of your comments in the other section. But the main message was to gradually increase what you're doing, and to be really kind and understanding to yourself, and not expect too much and not push yourself too hard. I think a lot of you agreed with that and probably are already doing it. And then lastly, Danette and I put this possible severity of symptoms score so we could communicate together. And of course, these type of things like the HPS needs to be validated and with statistics and such. But I think it was good to see that many of you thought that it would help you communicate with your provider or each other. And some of you mentioned that it was hard to know what the difference between moderate and severe was, and that might be better defined by you. And if you're your own control and you're feeling better, that's the best comparison. And it will be hard because hypopara is so variable and not always reflected in your calcium level hours or days later, of course, that it really, it all depends and comes down to how you're able to express your symptoms and treat them. So I'm going to stop there, and then later we can go through some of what other people had said, and I'll take some questions on the abstracts if you have any.
Okay, thank you, Dr. Kohlmeier. We do have a couple questions, but they're so long and detailed, we're going to just publish them so that you can answer them at your leisure. But again, I thank you, Dr. Mannstadt and Dr. Shoback, for spending time with us today and for always supporting us.
Awesome. Is there anything else you'd like to say, Bob or Deb, before we end this?
Other than I'm sitting in 10-degree weather, covered in snow and ice in North Dakota, I'm looking at that beautiful sandy beach and the waves, man, thinking how jealous I am right now. But no, I appreciate you guys and all the work that you do for us. And I want to thank everyone for attending today, and we look forward to seeing you guys tomorrow.
Don't forget to finish the silent auction.
Yeah.
Thank you all.
Thank you so much.
Thank you.
Bye.